इसके माध्यम से वो अपने अपने ज्ञान के क्षेत्रों में जो आयुर्वेद में नवीन कार्य हो रहे हैं। आयुर्वेद पर एक ही आरोप लगाया जाता है कि जो भी नेता आता है, जो हम लोग कार्यक्रम करते हैं, तो कार्यक्रम में हमको लगता है कि भाई पॉलिटिकल पब्लिसिटी भी आवश्यक है, तो किसी न किसी नेता को उसमें बुलाते हैं और वो एक ही बात कहता है कि आयुर्वेद के लोगों को शोध करनी चाहिए। उन लोगों को, शायद हम लोगों को भी ये नहीं पता है कि आयुर्वेद में दो प्रकार के काम है। एक तो शोध कितना हुआ है या कितना साइंटिफिक है। उनको लगता है कि आज की मॉडर्न भाषा में जिसको हम साइंटिफिक कह सकते हैं वही शोध है, बाकी आज और कुछ शोध नहीं है। तो हम लोग तो जानते हैं कि हमारे विश्व की रचना में पंचमहाभूत, और पंचमहाभूतों के बाद में पूरी जो संरचना है उसमें उस संरचना को, क्या आवाज पहुंच रही है क्या?
हाँ सर, सुन रहे हैं।
ठीक है, धन्यवाद। तो एक एक बात शायद सैद्धांतिक रूप में और व्यवहारिक रूप में बिल्कुल स्पष्ट है। जैसे अपने यहाँ मान लीजिए रस की कल्पना की गई, तो ये बताया गया कि भाई ये इस द्रव्य में इतने रस हैं। अब ये कल्पना करिए कि वो जब पैरामीटर्स क्या अपनाए गए, ये मॉडर्न पैरामीटर्स नहीं रहे होंगे, तो भी अगर आचार्य ने कहा कि इस द्रव्य का नाम रसोन है और इसमें एक रस नहीं है, या पंच रस वाले कौन कौन से रस हैं, तो वो आज भी स्वीकरणीय है। एक तो ये बिंदु। जहां तक शरीर रचना और शरीर क्रिया की बात है, ये ठीक है कि कुछ कंसेप्ट बदले होंगे, कुछ साइंटिफिक नए कंसेप्ट आए होंगे, उसके कारण से मूत्र का स्थान, लेकिन इसके बाद भी हमने हमारे ग्रंथों में हमेशा ब्रक्कौ शब्द का प्रयोग किया गया है। इसका मतलब है कि दो ब्रक्क होते हैं। ये आज से 5000 वर्ष पहले भी जो ग्रंथ लिखे गए उनमें स्पष्ट शब्द से रूप से कहा गया। तो ऐसा आज जो, जैसे मैंने प्रारंभ में कहा, ऐसे हर विषय पे तो विश्व आयुर्वेद परिषद ने, हमको लगता है कि आज के इस विद्यार्थियों को, आज जो कल के अध्यापक बनने वाले हैं, कल के शोध कार्य करने वाले हैं, या आज के जो शोध कार्य में पहुंच गए हैं, ऐसे सब लोगों को या नवीन चिकित्सकों को इस विचारधारा से, इस कार्य से जोड़ना। और हम लोग देख रहे हैं कि हम लोग कहीं, कोई काशी में है, कोई आगरा में होगा, कोई पूर्वोत्तर क्षेत्र में पटना में, बिहार में भी होगा, ऐसे सब जगह के लोग जुड़े हुए हैं। और जो सुदूर गुजरात का क्षेत्र है, वहाँ के जो विद्वान मनीषी हैं जिन्होंने इस पर काम किया है, उनके अनुभवों का लाभ हमको मिलेगा। तो ये विश्व आयुर्वेद परिषद की एक परिकल्पना है। एक दूसरी बात हम लोग ये भी समझते हैं, मैंने हम लोगों का जो विचार है कि शासन हम कह रहे हर्डल्स को दूर कर देगा, शासन कुछ सुविधाएं प्रदान कर देगा, लेकिन आयुर्वेद की उन्नति यदि करनी है, आयुर्वेद में यदि शोध करना है, आयुर्वेद में जो पुराना साहित्य है उसको एकत्रित करके उसको आज की भाषा में ट्रांसलिटरेट करना है, उसका अनुवाद करना है, तो ये आयुर्वेद के लोगों को ही करना पड़ेगा। और इसीलिए हम लोगों ने छोटे छोटे काम प्रारंभ किए हैं। जैसे जो साहित्य है हमारे पास वही बहुत है, लेकिन हमको पता है कि इस देश पे जो इन्वेडर्स आए उन्होंने हमारे साहित्य को बहुत नष्ट कर दिया, भ्रष्ट कर दिया। इसके बाद भी देश में लाखों की संख्या में पांडुलिपियां आज भी उपलब्ध है। कुछ मठों में है, कुछ मंदिरों में है, कुछ गवर्नमेंट एजेंसीज में है। हम सब पे काम नहीं कर सकते, लेकिन कम से कम जो गवर्नमेंट कर रही है उसमें जहां जहां सुविधा पहुंचा सकते हैं, तो हमारे पास जो डिफरेंट टाइप की पांडुलिपियां हैं उनको भी निकालना, उनको जो मलयालम में लिखी हुई है, कोई कन्नड़ में लिखी हुई है, कोई तेलुगु में लिखी हुई है, कोई तमिल में लिखी हुई है, उस भाषा के पांडुलिपियों को ढूंढकर उन उन भाषाओं के जो तज्ञ विशेषज्ञ लोग हैं वो उसको हिंदी और संस्कृत या अंग्रेजी इन तीनों भाषाओं में यदि ट्रांसलेटेड कर देंगे तो भी वो ज्ञान पूरे विश्व में फैलेगा। बहुत छोटी से छोटी कोई पुस्तक होगी, उसमें भी कुछ न कुछ ज्ञान ऐसा अवश्य होगा जो कि हमको अभी तक ज्ञात नहीं है। तो ऐसे विभिन्न क्षेत्रों में विश्व आयुर्वेद परिषद काम कर रहा है। सभी विषयों के भी हम लोगों ने ऐसी संभाषाएं या ऐसी परिषदें अपनी बनाई हैं। तो उनमें से काय चिकित्सा के सब विद्वान आज एकत्रित हैं। हमको नादियाड के जो प्रसिद्ध चिकित्सालय है, प्रसिद्ध कॉलेज है, वहाँ के प्रसिद्ध अति प्रसिद्ध जिन्होंने एक ही विषय को लेकर के काम किया है, ये भी एक प्रेरणा की बात है, मोटिवेशनल इसको आप स्क्रिप्ट समझ लीजिए कि हम लोग भी जो श्रोता हैं वो जो हमारे क्षेत्र में लोग हैं, जो हमारे क्षेत्र में उत्पन्न होने वाली वनस्पतियां हैं, जो हमारे क्षेत्र में रोग अधिक मिलते हैं, उनमें से किसी एक रोग पर कंसंट्रेट करके और अपनी शक्ति मन बुद्धि को लगाएंगे तो निश्चित रूप से आयुर्वेद की बड़ी सेवा होगी। ये निवेदन करते हुए वास्तव में तो आपको मैं चाह रहा था कि डॉक्टर पटेल का ही मार्गदर्शन हम लोगों को प्राप्त हो। तो ये विश्व आयुर्वेद परिषद के बारे में दो शब्द कहने के बाद में मैं पुनः सबका अभिनंदन करता हूँ और डॉक्टर अपना मंच फिर से संचालकों को सौंपता हूँ। धन्यवाद।
थैंक यू सर। प्रोग्राम हमारा सबके मार्गदर्शन से बहुत अच्छी तरह शुरू हुआ है। अब आई विल इनवाइट अवर डॉक्टर श्वेता शुक्ला। शी इज द असिस्टेंट प्रोफेसर इन द कायचिकित्सा डिपार्टमेंट, द ऋषिकुल गवर्नमेंट आयुर्वेदा कॉलेज, a part of the Uttarakhand Ayurveda University, Dehradun now. She will introduce Professor Manish Patel, sir.
Thank you so much, Dr. Nitin. A very good noon to all the respected dignitaries and dear students. Myself, Dr. Shweta Shukla, Assistant Professor, Uttarakhand Ayurveda University, Rishikul campus. Let me introduce Professor Dr. Manish Patel, sir. Sir is MD and PhD in Kayachikiotsa. Presently, sir working as professor and head in the PG department of Kayachikiotsa, JS Ayurveda College, Nadiad. That is NAC and NABH accredited, a constituent college of Magan Bhai Adenwala Maha Gujrat University, Nadiad. Sir has more than 20 years of clinical experience and more than 17 years of teaching and research experience. Sir published 43 research articles in reputed international peer-reviewed journal having good impact factor. Sir supervised 21 PG scholars and 8 PhD scholars. Sir started research work in 2008 and to evaluate the effect of Ayurvedic therapy in chronic renal failure, urinary incontinence, ulcerative colitis, nephrotic syndrome, cirrhosis of liver, diabetes, and its sensory polyneuropathies. Sir worked in the field of Ayurveda research together with some European scientists of Charité Medical University, Berlin, Germany, and of European Academy for Ayurveda, Boston, and Germany. He was also invited several times at Charité Medical University, Berlin, and at European Academy of Ayurveda, Boston, Germany, Switzerland, and Austria to deliver lectures on various points of Ayurveda. Since 2009, more than 5,000 hours speech delivered on principles and practice of Ayurveda in the Ayurveda education program for foreign medical and paramedical students from Germany, Austria, Switzerland, and more than 500 medical and more than 1,000 paramedical foreign personnel were clinically trained for Ayurveda practice by him. He was invited by Goa Council of Ayurvedic and other allied system of medicine, Government of Goa, as an expert for standardization of procedure for the management of CKD on 26 to 29th October 2023. SOPs was released by Honorable Chief Minister of Goa on 29th of October 2023. Sir is also a member of Reviewing Board in the World Journal of Transplantation, American Journal of Case Reports, Annals of Ayurvedic Medicine, for World Journal of Gastroenterology, Journals of Ayurveda Case Reports, and many other reputed index journals. Sir also got Outstanding Peer Reviewer Award by World Journal of Transplantation, which is indexed in PubMed, Scopus, and Web of Science, and run by one of the reputed B6 medical publication. So this was a short introduction about our reputed Professor Dr. Manish Patel, sir. And we are very fortunate that we have an opportunity to listen him. Now I hand over to Dr. Nitin Sharma, sir. Thank you so much.
Thank you, Dr. Sweta. तो अपने सभी कन्वीनर्स, कोऑर्डिनेटर्स जैसे पटेल सर, मनदीप गोयल, डॉक्टर मंजुला, डॉक्टर सुजाता यादव फ्रॉम पीवीआर कॉलेज, डॉक्टर माधुरा दीदी सर फ्रॉम गवर्नमेंट कॉलेज बेलगवी, Professor Sudhanshu Tripathi from Bihar, Professor Aruna Ojha Madam, HOD Kayachikiotsa, Government College Raipur, Dr. B.N. Sharma sir from Government Ayurveda, Government University Jodhpur, and Dr. सभी को मैं स्वागत करता हूँ. Maybe missing the name of anyone, but from the core of my heart, I welcome all of you. ऑफिशियल इंट्रोडक्शन डॉक्टर श्वेता ने दिया है, लेकिन फिर भी मैं 2-3 चीज ऐड करना चाहूंगा कि हमारे आयुर्वेद में गवर्नमेंट जॉब का बहुत प्रचलन है और एवरीबॉडी जस्ट ट्राइंग टू गो फॉर द गवर्नमेंट जॉब. लेकिन हमारे जो प्रोफेसर आज के स्पीकर हैं ये ऐसे हैं जिनको गवर्नमेंट जॉब का बहुत बार चांस मिला, लेकिन उन्होंने गवर्नमेंट जॉब में ना जाते हुए प्रैक्टिस को और इधर ही अपना कैरियर बनाना बहुत उचित समझा. तो ऐसे ये भी एग्जाम्पल है कि जिनको हमें फॉलो कर सकते हैं हम लोग अपनी प्रैक्टिस को आगे बढ़ाने के लिए. और अभी किडनी के ऊपर हमारा एक विषय परिषद के बैनर पे लास्ट वीक ऑफ अप्रैल में केवल किडनी के ऊपर 5 दिन का एक लेक्चर सीरीज आयोजित होने का प्रस्ताव है, जो कि अप्रैल के लास्ट वीक में संभावित है. तो सर भी उसमें सर ने कंसेंट दी है, सर भी उसमें एक हमारे स्पीकर होंगे. 5 दिन हम लोग केवल किडनी के ऊपर डिस्कशन करेंगे. बहुत ही नॉमिनल फीस के ऊपर वो होगा और वो विषय परिषद के बैनर पे ही होगा. तो सर्विस में स्पीकर है, तो और ज्यादा डिटेल हम लोग जो सुनना चाहते हैं तो वो उसमें हम लोग ज्ञान ले सकते हैं. और एक प्रोफेसर एस एन गुप्ता सर है, सर उनके स्टूडेंट हैं. सबका जर्मनी में इंडिया के नदियाड में बहुत अच्छा काम है एस एन गुप्ता सर का, और सर ने उनसे ही सब ग्रहण किया और उसको काम को आगे बढ़ा रहे हैं. तो लास्ट में अगर फीजिबल होगा, मैनेजमेंट की बातें हमारे विषय परिषद चौधरी सर की और एस एन गुप्ता सर की हुई भी थी. तो अगर जैसे जैसे फीजिबल होगा तो 2 दिन का वर्कशॉप अगर नदियाड कॉलेज में ही विषय परिषद के बैनर पे अगर इस टाइप का पॉसिबल होगा तो आगे फ्यूचर में हमारे इस अप्रैल के लास्ट वीक के जो प्रोग्राम होगा ऑनलाइन, उसके बाद फिजिकल प्रोग्राम की भी संभावना तलाशी जा रही है. तो हम लोगों को पर्टिकुलर चीज के ऊपर, किडनी के ऊपर काम करने का जो प्रैक्टिकल हम लोग देखेंगे तो हम लोग उसको और ज्यादा ग्रहण कर पाएंगे. तो यही शब्दों के साथ मैं प्रोफेसर मनीष पटेल सर को इंट्रोड्यूस आमंत्रित करता हूँ स्पीच देंगे. तो सर विल गिव द स्पीच फॉर द 30 to 40 minutes and then there will be 5 to 10 minutes question answer session. Program will go like that. Thank you, sir. Professor Manish Patel.
Thank you, Nitin Sharma ji. Thank you, Dr. Sweta, for introducing me. Many much more. So, I have already shared the screen. It is visible.
Yes, sir, it is visible.
And also, is it audible? Everything?
Yes, sir. Slightly volume, if it will be increased, it will be better. And the screen can be also maximized also for the good visibility.
Yes, now it's maximized. And
yes, sir, yes, sir.
it is movable? It is moving?
No, sir, it is not moving.
Moving?
Only first screen is coming.
Okay, so I think we have not used this PowerPoint presentation specifically with the whole screen.
Okay, sir, you can go like this only, no problem.
Okay. So the today's topic is Ayurveda management of chronic kidney disease, and whatever I am sharing as here, it is my practical experience. So the total practice oriented things which I have observed since 1994 during my practice related to chronic kidney disease, that's I am sharing it here. So first of all, this is my preceptor, Professor S.N. Gupta. He is the pioneer of the management of the CKD, and he had started to treat the patient of CKD since 1990 when I was a student of this bona fide college. At that time, he was my professor, and it is my proud that presently I am working with him. And now he is a vice chancellor of this university. So now we jump directly into the chronic kidney disease. So as we know that chronic kidney disease, it is a irreversible deterioration of the renal function, and it's developed generally over the period of years. It requires many years to develop. But now since last 5 years during my practice, I have changed. I have already seen that something is changing. This scenario is changed. Earlier, before 10 years, when patient come to us in the ESRD stage or in the last stage of the kidney disease, and when we take the history, we found that they require nearly more than 10 years, or some patients require more than 20 years to develop the end stage. But since last 5 years, the history of the patients of the CKD shows us that the end stage renal disease or end stage of this chronic kidney disease comes within a 2 years to 5 years period. So scenario is changing, and now this history or these types of experience, I observed that now it is very much problematic for society. Now chronic kidney disease becomes dangerous, and main etiology of this chronic kidney disease is diabetes mellitus. Second one is hypertension, glomerulonephritis or interstitial nephritis, polycystic kidney disease, analgesics and other nephropathies, autoimmune, and some causes which is we cannot identify or modern medical science has not still identified. We can conclude them as a non-specific reason. So earlier, as per the classical modern conventional textbook, the first main cause diabetes mellitus for chronic kidney disease, it's mentioned as a 40 to 45%. It means that 40 to 45% cases of the CKD, they generally because of the diabetes mellitus, and nearly 20 to 25% cases of the CKD, they have the CKD because of the hypertensive or the cause is of hypertensive. So 20 to 25% is hypertensive nephropathy patient, and nearly 40 to 45% are the diabetic nephropathy cases. And rest 15 to 20% they are chronic glomerulonephritis, and rest of the causes are in the very fewer amount, less than 5 or 6%. But I have also made the question mark in this slide, because during practice I have observed more hypertensive cases since last 5 years than diabetic cases. So again, this is again challenge for us. Now we have to go for the further studies which can highlight the causative factors or the risk factors, which is more. Earlier the risk factor is diabetes mellitus more than the hypertension, but now during practice I have observed that hypertension is more than diabetes mellitus. So this is the time now we have to go for the etiological research or some epidemiological research. The risk factors which I have identified from many evidence-based clinical research. The main risk factors which is mentioned in the classical or in the nephrology and kidney disease related or urology related some research journals. First is the low socioeconomic status, lifestyle related changes, diet pattern which we have already changed, stress and phobia, heating stress from inner side and from outer side both, and recurrent dehydration. These are the main 5 risk factors which identified in many research journals related to the chronic kidney disease. When we think about the pathophysiology of the chronic renal failure, the main thing is damage of the kidney or the nephrons. At initial level, it is in the minor form, but when we persist the causative factors, its continuation, then kidney damage is more and more, nephrons are more damaged more and more, and those nephrons which are alive because of their overburden, some compensatory hypertrophy of the survival nephrons will be there, and extra burden of the surviving nephrons which also lead them for the further damage, and ultimately patient goes into the end stage renal disease which require renal replacement therapy. Either patient must have to go for the renal transplantation or hemodialysis. Earlier in 2015, the 10% of the population of the world, they are affected with the chronic kidney disease, and over 2 million people, they are taking the renal replacement therapy, any one of the hemodialysis or the renal transplantation. But these are of 2011 and 2015 data. Since last 2020, it is changing and it's more and more. So disease burden, the data which we do not have after the 2015. In 2020, the Lancet has published the danger rank of the CRF. Earlier in 1990, the CRF as a cause of the death in worldwide, it is 27th number. But in 2010, it is on the 8th number. And in 2012, so 17, it is the rank of the CRF as a cause of the death is of 12. So now we can put the CRF as one of the most danger condition which is responsible for the death. Globally in 2010, 2.62 million people, they require the hemodialysis to live. And expected that in 2030, this number will be double, 5.24 million. So these are the modern medical science which we know about the chronic kidney disease. But what we think about the CKD in our Ayurveda, as we know that in Ayurveda there is no any clinical entity or nomenclated clinical entity in our classical textbook which can directly correlated with the CKD. So as per our Charak Sutrasthan chapter number 18, they mention that if you do not know the name of the disease, and if you know or if you have a good number of and good knowledge of the analysis of the dosha, dushya and srotas or the dushti of the srotas and causative factors or nidana, then you can treat any of the disease. So we have to go through these bases, because in clinical or in classical textbook in Charak Samhita, Susrut Samhita or in any Lagutra, we do not have a full description about the chronic kidney disease. There is no any clinical entity which can directly correlate it with the chronic kidney disease or chronic renal failure. So first we go through the nidana, which causative factors are responsible for development of the CKD in the patient. For that purpose, we have conducted one research to find out the nidana on the patient of the CKD. For that purpose, we have conducted one epidemiological study, and that study was funded by our Central Council of Research of Ayurveda, CCRS, New Delhi. A report already submitted to them. And in this research, we found that the Nidana, this Nidana which is mentioned in our classic. We want to find those types of Nidana which is mentioned in our according to our Ayurveda classes. We don't want that diabetes or hypertension. That's we already know from the modern medical science. But according to our Ayurveda, Nidan Panchak is not mentioned as a separate clinical entity in classic. So we have to find out the Nidan Panchak. For that purpose, this research was conducted. And we found first one is the Daiva Vega Dharana, specifically Apana Vega, certain Mutrava Srotas and Medodushti related disorders. First one is Ashmari, Mutrakritra, Prameha, and Sthaulya. These are the main four causes which we have identified in many of the patients as one of the causes of the CKD. Another is the Vishamashana, Bijadushti, and Balabhramsha, that is the Amadosha or autoimmune problem. Another risk factors which are not found in many of the patient but found in certain patient as a secondary causes or may not be a primary causes. So we found them as a risk factors. There are the Mansahar, the older aged peoples, Chirkalin Malabadhata, chronic constipation, or specific stress like Autsukya, Bhaya, and Chinta, excessive intake or lavana and amla in the food, history of the udavarta. This is very classical picture which we found in the many patients, that udavarta history. As we know that Trimarma Chikitsa Adhyay Charak has mentioned Udavart first and then they start all other Trimarma disorders. Why they have mentioned Udavart first, which is not of the Trimarma disorders, even after that it is mentioned in the Trimarma Chikitsa? Because if we neatly observe that the Udavart is the main cause for all Trimarma disorders. If heart disease, kidney disease, or Shira or brain and spinal cord related disorders are there, these three Marma disorders, patient have history of Udavart. So that's why Udavart is mentioned first in Trimarma Chikitsa Adhyay, and then they have started all other description about the Marma disorders. So Udavart history also we have found in some of the patient. Nidra Viparya, Bharadva means the excessive physical work beyond their capacity. These are the main risk factors which we have identified in the many patients of the CKD. So, which dosha is responsible for the CKD? So, Tridosha is the responsible. This is the dosha of the Sannipata's disorder is there. All Tridosha took place in the pathophysiology of the CKD. But as we know that kapha is responsible for the blockage of the microchannels. So, in diabetic mellitus and another causative factors, mainly the microchannels are obstructed, they blocked, and then the nephrons start the albuminuria and then slowly develop the nephropathy and other stages. So initially the kapha has started the pathophysiology, specifically in diabetes mellitus and another patients. Those patients who has inflammatory changes in the kidney and then they develop the CKD, we can say that the pitta is initial or responsible to start the disease, and then the another dosa is associated, and then development of the CKD. And in hypertensive and all other causes, in the later on also, after the initial stage, all the stages, the VAT is responsible for, because VAT is having a Lagu, Ruksha, Parusha, and Khara, these types of Amsamsa Kalpana. And these types of Guna, with the help of the aggravation of this Guna, the Vata provoked, and they create the degeneration of the Dhatu. And at here, the nephron is the Dhatu. And they are degenerated. So what is responsible for the degeneration of the structure or the parenchymal cells of this kidney, which are the functional cells, and ultimately the patient develop the later stages of the CKD. So all three dosas are responsible, but initiation may be by kapha, maybe by pitta, and maybe by vata. It depends. What are the main causes is continually patient is suffering from, and they, because of them, any one dose it start the nephropathy, and all other dosas are slowly associated. and they develop the CKD. Dushya, which are the pathological form of the dhatu which involve inside these CKD patients. So when patient start or the development of the CKD is at initial stage or first stage, the mutra, rasa, udaka, sveda and rakta dhatu, they are the basic tushyas. Sira also you can consider, Sira as a upadhatu, but dhatu, upadhatu and mala, these are the dushya. So Sira is a upadhatu of the rakta. So if you consider rakta, then also, but at here specifically micro vessels are blocked, and that's why I have write Sira specifically at here. So these are the dushya basically, or initial stage they take place as a dushya for those dushya samurjna. And when patient is in the later stages or at the end stage, all the dhatus and updhatus, they are involved as a dushya. So that's why in the later stage patients are nisara and very less oja in the patient's body. They feels very much weakness. The cachexia are there because all dhatu they involve as a dushya. How we can consider them? Because symptoms and signs which is mentioned in the modern medical science as a picture of the CKD. So we know that the imbalance fluid and electrolyte. Hello. Hello. Is it audible for everybody? And slide is also
Ji
visible
sir,
for
yes,
everybody?
audible sir, audible.
Okay. So fluid and electrolytes imbalance is always present in the patients of the CKD, not at the initial stage, but mostly in the second or third stages of the patient of the CKD. And from very beginning, the low immunity is there. Cardiovascular risk is also higher in the patients of CKD. So these are the main factors which, because of these factors, we have to consider that rasa and udaka dushti is present inside the body. Anemia is common features and also complications. Bleeding tendency is also complications of the patient of the CKD. So rasa and rakta dushti we can consider through this way. Myopathy, cachexia, muscles wasting, lost, muscles lost. These are the mansa dushti. Some dyslipidemia, specifically high cholesterol level, and also the lipids, which is imbalanced inside the body. Cachexia is there. Made or fatty tissues are degenerated inside the body. Patient's weight loss is there. These all are, according to our Ayurveda, it is Medas Dushti. Renal osteodystrophy is the common complication of the patients. That's why all the patients, they take the vitamin D3 and calcium supplements when they come to us for the treatment. So osteodystrophy, that we can consider as a Asti Dushti. Many patients, they have numbness in their feet, burning sensation, or allodynia types of symptomatology that consider the peripheral sensory neuropathy, that is Majja and Snayu Dushti, and loss of libido or sexual dysfunction, that is Sukra Dushti. So these all are the classical clinical features of the CKD. And according to these clinical features, we can consider that as per the Ayurveda, all the dhatu, they involve at here, at maybe in the first or second stage or maybe in the last stage. It depends how much the patient's having the symptoms and signs. The srotas, which is involved in the cases of the CKD patient, that is the mutravaha, udakvaha, svedvaha and rasavaha, raktavaha srotas. But when the disease advances or in the later stages, all the multi-srotas or measure of the srotas they involve. Type of srota dushti is Sangha and the Vimargagaman. Actually, Ati Pravritti and the Siragranthi is also sometimes happen in many patients, but not in all. Because we have found sometimes cystic involvement inside the kidney when we tell to the patient for the sonography, and in sonography report, we found there also some of the cysts because of the overgrowth of the nephrons. So that also we can consider as a Siragranthi of the Srota Dushti. But mostly in all the patients, Sangha and Vimargagaman are there. According to Agni and Ama, general Agni is low, and at every level, and Mal Sanchay Rup arm is present. As Vijay Rakshit ji has mentioned the 4 types of arm: Jatragni Mahandajanya, Dhatvagni Mahandajanya, Mala Sanchay, and Prathama Dos Dushti. I personally believe that Mala Sanchay Janya arm is present in the patients of the, because Agni is already Manda at every level, Jatragni level, Dhatvagni level also. So Jatragni level and Dhatvagni level Janya arm also present inside the body. But as per the laboratory value, creatinine level is high, blood urea level is high, then we say that this is the patient of the CKD. Because our major parameter for the diagnosis of the chronic kidney disease is creatinine and the blood urea. So when they are high inside the blood, it means that the mala sansaya inside the body is there. Because mutra rupi mala, there are 3 mala: mutra, sweda, and purisha. And mutra, as per the Ashtanga, mutrasya kleda vahanam, means mutra is directed the kleda, so kleda is eliminated by the mutra from the body. This is the classical statement from the Ashtanga as a karma of the mutra. So if you consider that someone is directed another things from one direction to the another direction, means the both things are separate. Means according to Ayurveda, the mutra is alag, this separate, and the kleda is separate. If we consider kleda as a watery substances, then urine is not a mutra. According to Ayurveda, mutra is equal to urine minus watery substances. With the solutes which is inside the urine, they are the mutra according to Ayurveda. So that's why solutes, which are the solutes? Solutes inside the urine, they are the creatinine level, urea level, all other toxins, some sodium, potassium level. So if they are raised inside the body, that means mutra sanchay is there. That's why I personally believe that mutra sanchay rup arm is present inside. Pakvashayot is the Udbhav Sthan, and initially Madhyama Rog Marga, because this is the Basti disorder, and Basti is one of the 3 marma. So marmasti sandhi, that is the Madhyama Rog Marga. So initially this disease is Madhyama Rog Marga, but when patient is in the advanced stages or in the 2nd, 3rd, or 4th stages, many symptomatology are present inside the body. And according to the symptomatology, we can consider as all the Rog Marga is involved. And that's why it is incurable. So this is the CKD, how we can understand the chronic kidney disease according to Ayurveda. This is my personal belief. And also I have observed in many patients, according to that observations, how we can consider the CKD in our Ayurveda way. That's I have presented it here. Now, according to this disease, the treatment protocol or the line of the treatment, Chikitsa Sutra, and generally we follow the Chikitsa Sutra as it right at here. First, Nidan Parivarjan. Second is repair of the Vyadhi Adhisthana, which is not always and every time completely possible, but some kind of Vyadhi repair is possible. The third one, that is Mala Nirharan. As I told you that Mala Sanchay Rup arm is present inside the body of the CKD patient. So Mala Nirharan is also the third treatment protocol. And the fourth one is the Dhatu Poshan by Rasayana Karma. Because all Dhatu is involved as a Dushya. So we have to give some support to the Dhatu. And Dhatu Poshana is required. So Rasayana Karma is also required as one of the treatment. So these are the main 4 treatment protocol. And according to them, first one is the Nidan Parivarjan. These are the list of the pathya which we give to the patient. This is practical. I am not telling those things which is according to Ayurveda classics like this, and this is mentioned, not like that. This is the thing which I have used since many years. These are the list. what are the pathya? We give to the patient, suggest to the patient that don't take any types of flour except rice flour. So no wheat, no barley, no millet, no any types of flour. If patient want to eat chapati, they can use only rice flour chapati. Or rice related another items. Or they can use the mung beans flour and rice flour, both they mix them and then make the chapati. All other beans or all other grains, they are prohibited or just restricted. Vegetables, those are light and to digest and not too much slimy, like bottle gourd and pomegranate. These are the fruit sweets. Fruit sweet, apple and papayas, dates and pomegranate also we allowed them. But pomegranate sometimes if they take the juice, then it's okay. Otherwise, the very small bees which is inside, they also create some harmful effect in the patient. So fruit, sweet apple, papaya and dates, these we are allowed them. Limited amount of the Sandhav lavana, no any other lavana, no sodium chloride or simple salt. Sometimes those patients whose creatinine level is less than 2 or they are in the stage 1 from very beginning and from very long time, they are taking our treatment from a longer period and no symptomatology or asymptomatic are there. Sometimes, not always. We allowed them 1 or 2 chapati of the barley flour. And when they use the any oil, only sesame oil we allowed, and ghee, preferably cow ghee or homemade ghee. But only ghee oil is not for deep frying, just to shallow frying or to make some or cooking with the vegetables, only for that purpose. And for Rasayana, we prefer Chivan Prasavaleha and Brahma Rasayana every day in the morning with some milk as a breakfast. And these are the list of the apathya, all flour items, bakery items, all the oils except sesame oil, junk food, fermented items, salts, chilies, deep fried items, milk products, excessive physical and mental stress, day sleep and night vigil. These are the apathya for the patient. So Samana treatment, which mainly create the Vyadhi Adhisthana repairing. So for that purpose, we give the Lekhana and Mutrava Srotas Rasayana treatment, specifically Varunadi Kvat. Varunadi Gaun is mentioned in the Susrut Samhita for Medova and Medas Dushti related problems. And Vrukau is from the Medava Srotas. It is the root of the Medava Srotas. So we have started this Varunadi Kvat and we found good result in the patients. So Varunadi Kvat, and these are the other ingredients which is mentioned here. Goksuradi Gugulu, that is 1 gram 3 times in the with the warm water. Rasayana Churna, it is mentioned in the Ashtangradaya. In North India, generally Rasayana Churna is not familiar, but in our Gujrat and Maharashtra, Rasayana Churna is very effective and many Vaidyas they are using. And it is also mentioned in the Ashtangradaya. It is a equal portion of the Gokshura, Amalki and Guduchi. And another thing, Bhumyamalaki. Bhumyamalaki is a very neglected word. These drugs or medicines for our Ayurveda. Many patients, many persons or physicians, they are not using Bhumyamalaki. But we are using the Bhumyamalaki in the many patients of diabetes, all the complications of the diabetes, and in many patients of the CKD. And we found a wonderful result of the Bhumyamalaki in specifically peripheral sensory neuropathy because of the diabetes mellitus, and also in the nephropathy of the diabetes mellitus. So Bhumyamalaki is one of the most important medicines. And third one is the Shodhana, because Mal Sanchaya, Mala Nirharana is most requirement. So Niruha Basti, because I believe that patients, they have Udakva Srotas Dushti. They have Shot means the swelling, and electrolytes imbalances are there. And Kleda is excessive. So if you go for Virechana Karma, then Snehapana is generally contraindicated in the third or the later stages of the patient. But initially you can go for the Virachana or Snehapana also. But most of the patient, in all the patients, we perform the Niruha Basti every day before the lunch. And these are the ingredients which using for the Niruha Basti. Niruha Basti generally we 300 or 320 milliliter. So it just support the excretory functions of the kidney. How we can expect the mode of action of the Niruha Basti? It is also as per the classical way we can understand it as a root. If you pour the water, then it goes into the each and every part of the plant, and then the same way also with the same example, this basti which you have administered, the medicines through the basti which you have administered in the proctocolon, they also goes in each and every part of the body and come at the Pakvashaya with many mala, and it expel the mala through the colorectal route. So that's why it is called as the Niruha. This is the classical statement mentioned in our Charak Samhita and Susrut Samhita. So as per this, we use the Niruha Basti as a one of the supporting excretory phenomenon. And for Rasayana medicines, we are using Rasayana Churna, which we already Bhumyamla ki Churna, Chavan Prashavale and Brahma Rasayana, which create the Dhatu Poshana. And those patients of the CKD whose CMD means the corticomedullary difference. This is mentioned in the sonography report by the sonologist. When the patient come to us, if we see the sonography of the kidneys or KUB, we have our observation is related to the CMD. If cortex and medulla difference in the kidney, if it is well maintained, that means most of the nephrons are still alive and their work capacity is there. Maybe if creatinine is rising much more, it means that the functional disability is there. There is no structural deformities is there. So CMD, if it is maintained or serum creatinine level is less than 3.0 and no any other symptomatology is there, then we also perform the Virechana karma with the Snehapana of Guksuradi Grit. In these types of patient, we start the Snehapana with Guksuradi Grit as per the requirement of the classics. And after that, Abhyanga Svedana for 2 days, and the third day, Virechana karma. And then followed the Sansarjan karma for next 3 to 5 days. And then all the medicaments which we have seen in the previous slide, that all medicaments and the Nirubasti every day, that we continuous with this patient. But those patients who are in the later stages, directly they come to us for the Ayurveda treatment. We cannot go for the Snehapana and the Virechana karma. So in that cases, we directly start the Nirubasti and all the oral medicaments. So without Virechana, we start that medicaments. Now some avasthiki or symptomatic treatment also we are using in our patients. If patient is with nausea and vomiting, we give Chadiripu Churna 1 gram or 2 gram in 2 to 3 times. If patient having hyperacidity syndrome because of the uremia, then we use the Sankhapasma. And if patient has low urine output, excessive swelling or fluid accumulation, then we go for the Punarnavak Churna in 3 gram 2 times, and also Yavakshar in 300 milligram quantity 2 times. When patient has muscular cramps, weakness or body ache, we give the magnesium sulfate. Actually in the classic Sindhu-Thalavan is mentioned, but Sindhu-Thalavan is not originally available. So we use the chemical component which is available, magnesium sulfate. And Sindhu-Thalavan is mostly similar with the magnesium sulfate. So we are using the magnesium sulfate. So it supplements the magnesium, and that's why the muscle cramps and weakness or body ache, that will be disappeared. Most common complications is the low level of the hemoglobin or anemia. For that purpose, we use the Dhatri Loha or Lohamrit tablet, Ayurvedic pharmacopoeia. And in severe anemia, we generally prefer the blood transfusion. Low serum calcium and high serum phosphate level, we use the Asti Srinkhala Grit, not in the Shodhanartha Snehapana, but at the Samanartha Snehapana, 20 milliliter 2 times every day. In hyperkalemia, we restrict the fruits remove the water from the vegetables after the boiling and use the Tikshna Niruhabasti. In hypokalemia patient, magnesium sulfate, coconut water, fruits, and Sarjikakshar or Yavakshar into 50 milligram 3 times. In hypernatremia, also the magnesium sulfate and Punarnava Churna. So some evidences I show you. Every day or every year we have nearly 4,000 to 4,500 patients, and every year 350 to 500 new indoor cases. Sorry, total indoor cases, and among them 300 are the new cases. So these are the flow, and we have the patients flow from every corner of the India. Presently also we have 2 patients from Bihar and 1 patient from Odisha in our hospital. So we have every corner of the India related to the CKD patients. Many patients we had, much more flow every year. So that's why we can consider some kind of research is related to the CKD. And all the treatment which I have shown you in the slides, the result of that treatment now I am showing to you. These are the publications related to the only CKD in many reputed journals. This Ayu and Journal of Ayurveda and Integrative Medicines and this Journal of Alternative Complementary Medicine. These all are indexed in PubMed, Scopus and Web of Science. So generally we never send our research article to any of these publishers, which publications are or which journals are not indexed in any of these Scopus, Web of Science or PubMed. In first research article, these are the result of the GFR, which is mentioned in this slide. Before the 6 months of the starting of the Ayurveda treatment, when patients are taking some antihypertensive or another allopathic medicines, or not taking any types of medicines, whatever they are doing, but not taking any Ayurvedic treatment at that time, within that 6 months period, this GFR was deteriorated up to 20.58. It was mean value of the GFR of all the patients are 20.58. And after the 6 months of that treatment, when they come to us, that GFR is low, means the condition is deteriorated within that 6 months period. And the GFR was found as 11.95 mean value. And that's why they admitted it here and start the Ayurveda treatment. So after the 6 months of the Ayurveda treatment, this GFR is raising and it becomes 17.01. So you can see the difference. Before taking up the 6 months of the Ayurveda treatment, the condition is deteriorated. The GFR is decreased from 20 to 11. And when they start the Ayurveda treatment, it goes up it becomes 17 from 11. So GFR is raising. Score of the signs and symptoms are also at here. Majority of the symptoms and signs, breathlessness, weakness, nausea, vomiting and swelling, they are significantly decreased within the 6 months of the Ayurveda treatment. So all these results or these research studies were performed only on those patients who are on the stage 4 and 5, but not on the hemodialysis. Means advanced stages, stage 4 and stage 5 patients of the CKD. So all the 53 patients, they are at the level of the Ayurveda treatment, at the level of RFT 0. All the 53 patients, they are in the stage 4 and stage 5. And before the 6 months, they are in the, many patients, they are in the stage 3 and stage 2. And after the Ayurveda treatment, from 53, only 30 patients are in stage 5 and rest of the patients, they are in stage 4. But 7 patients, they are treated in stage 3 and stage 2. So Ayurveda treatment is effective to just reduce not only the symptoms and signs or reduce the creatinine level or increment of the GFR level, but they also shift to the patient from advanced stages to the non-advanced stages. So another research studies at here also the same phenomenon or the same research design we have obtained, and these are in more than 200 patients. 216 patients was enrolled, and in these cases we have found that creatinine level is decreased, urea is decreased, GFR is increasing, but the hemoglobin level is not as much increased. So hemoglobin level is we have less success. These are the 3D pictures of the research results. And in the patients of the dialysis dependent, in last 1.5 years, total we have total 48 patients who are on the hemodialysis. And among 48, after the 6 months of the Ayurvedic treatment, 25 patients, they do not require the hemodialysis. Only 23 patients, they are on the hemodialysis. And when we think about the frequency of the hemodialysis, before starting the Ayurveda treatment, the monthly per month 5.9 frequency of the hemodialysis, that is, this is the mean value. But after the 6 months of the Ayurveda treatment, these 23 patients who are on the hemodialysis, they require only 1.73 frequency per month of the hemodialysis. So Ayurveda treatment is able to reduce the number of frequency up to the 25%. So 75% reduction are there. Only 25% is requirement of the hemodialysis. And GFR is also increased from 7.7 to 9.27, and serum creatinine level is also near to same. And even near the same creatinine level, they do not require the hemodialysis. So this is the real effect of the Ayurveda treatment, which we already discussed. In blood urea, it is also decreased, but the hemoglobin level, we have not much more success. It is decreased 9.8 to 9.3. So for hemoglobin level, generally we have to give the suggestion for the blood transfusion, or we also suggest them if they are already taking the erythropoietin injection, they have to continue. Now, since 15, 17 years, I am engaging with the real practice of the Ayurveda in the CKD patients. What are my observations? Or what are our clinical team's observation? I observe that if CMD is preserved, or corticomedullary differentiation is altered, then the patient's response or Ayurveda treatment is more effective. But as kidney size is reduced or shrunken kidney size or CMD lost, then little bit less response is there. Patients who are on diabetic nephropathy, they are more successfully treated, but those who has autoimmune etiology, they have little bit less response with the same Ayurveda treatment, which we already discussed. And special observation related to the herbal medicines that ashwagandha, jatamansi and yashtimadu, they are harmful for the patients. Punarnava is sometimes useful, sometimes harmful in the patients of the CKD. Rasaushadhi deteriorates the GFR, specifically those Rasaushadhi which includes the Parada and Dhatu Bhasma. But Mandur Bhasma or low Bhasma, we have used, and we do not found any unwanted or deterioration of the disease progress. Daivapasraya Chikitsa is required. Daivapasraya and Sattva Vajay, because positive mental attitude is always much more effective and they enhance the effect of the treatment. So that's why Daivapasraya Chikitsa. In our institute, we start our work with daily Agnihotra. we start our work with daily Agnihotra and we finish our work with Vishnu Sahasranam from many years. And during our Corona also, in our campus, we do not have much more emergencies related to the Corona. So, Daivya Chikitsa has its own role, as mentioned in the Charak Samhita, that Vishnu Sahasranam is good for the Jwara. If you cannot treat the Jwara with the Ayurveda medicines, then only one medicine, that is the Vishnu Sahasranam. Actually, member secretary में करवाना है. मेघना मैंने Sattva Chikitsa is also require some integrative approach. See, this is my personal opinion that Ayurveda is no doubt is good, but presently many things which is mentioned in the classics we do not have. We do not have a much more experienced physician. We just like in Charak's Charak era, we do not have a good medicines which have as much as potency presented or written in the classics. So many limitations we had now. And also, not only these medicines, but each and every pathis, each and every person, they have their own limitations, and Ayurveda had also. So integrative approach is required in these types of cases, specifically those patients who are in advanced stages. So conventional medicines is required, specifically antihypertensive agents, or those patients who are diabetic and taking anti-diabetic medicines. When they come to us for the Ayurveda treatment, initially we continue as per their requirement of the doses, but when they respond with the Ayurveda treatment, we can reduce the doses of the conventional medicines, or eventually some patients we are able to stop them also. But conventional medicines or integrative approach is required at initial stage. Specifically, those patients who are in the third, fourth, and fifth stage, integrative approach is most essential. And in the first or second stage, very less requirement is there. So Ayurveda treatment can reduce the need of the dialysis, and therefore we can postpone or reduce the frequency of the hemodialysis, or we can postpone the renal transplantation if we are treating the patients at the initial level. If patient come to us at the first or second stage, then without hemodialysis or with good life quality, we can extend the life, we can postpone the dialysis, or we can reduce the requirement of the hemodialysis, we can postpone the renal transplantation, even surgery also. So thank you very much. And questions are always appreciable, because which is in my mind I have presented it here. If you have question, you can ask. If you ask the question, then you will have more. So questions are appreciable and accepted at here.
Thank you, sir, for your nice lecture. और सर ने जैसे ऑब्जर्वेशंस जो बताए हैं, सर का लेक्चर पूरा ही अच्छा था, थ्योरी से लेके कौशल निदान से लेके संप्राप्ति और चिकित्सा उससे उसके उपद्रव सर ने सभी कवर किए हैं। और जो ऑब्जर्वेशन है, कौन सी ऑर्जी अच्छा काम करती है, कौन सी ऑर्जी हमें नहीं देती है, कौन सी रसोर्जी टेक्निक्स अच्छा काम करती है, कौन सी दे सकते हैं, और जो पूरा डाटा एनालाइज करके रखा है, वो डाटा ही भी हम सबके लिए एनकरेजिंग है, रियल डाटा है वो। और सारे कॉम्प्लिकेशन इसमें हमें ट्रीटमेंट करते समय कौन सा कॉम्प्लिकेशन आएगा, उसमें कौन सी ऑर्जी देनी है, उनके एक्सपीरियंस से सर ने वो भी हमसे शेयर किया। और देव आपस में चिकित्सा को भी उन्होंने इंक्लूड करते हुए अग्निहोत्र और विष्णु सहस्त्रनाम का जो जिक्र किया, वो भी हम लोग अपनी प्रैक्टिस में फॉलो कर सकते हैं। और लास्ट में सर ने इंटीग्रेटिव अप्रोच के लिए भी कहा, तो बहुत ही अच्छा सर का लेक्चर था। और सर ने सारी चीजें इतने कम टाइम में कवर बहुत ही अच्छी तरह उन्होंने अपना लेक्चर प्लान करके और शॉर्ट टाइम में उन्होंने सारी चीज कवर करने की कोशिश की है। आगे हम जो अप्रैल के लास्ट वीक में हमारा क्लिनिक प्रोग्राम होगा, तो उसमें हम और डिटेल में सर से वो चीज सुन सकते हैं। अब किसी के कोई क्वेश्चन है तो आप ले सकते हैं, डॉक्टर वीरज शुक्ला जी का क्वेश्चन है, व्हाट द सर्दी रिपू ड्रग कंटेन्स?
Sardi Ripu is only the one medicine, that is Sardi Ripu. The botanical name I don't know, but it is easily available at everywhere, and we call it Kapur Kanchli or Shatkachur. Shatkachur in our Ayurvedic classical textbook, Shatkachur is mentioned in Bhavaprakash or other Nigantu, that Shatkachur, it is Sardi Ripu. Only single medicines, it herbals.
Any other questions? You can either unmute yourself and ask directly, or you can write in the chat box.
For nausea and vomiting, we also use sometimes whenever the availability is there, Amra and Jambu Pallavaras. So when the very small or initial stage of these leaves, so it is very shorter timing period is there, availability is very short period, but whenever available we also use, and we found that they are the wonderful effective in the patients, specifically those who has a nausea vomiting because of the uremia or uremia induced nausea vomiting. This will be subsided within a shorter period when you administer this Jambu Pallavaras or Amra Pallavaras.
Chat box में क्वेश्चन है, what to a pregnant lady who diagnosed as a renal stability in her second trimester during ultrasound? Manish sir?
I have one in the chat box. One person has asked the question: इस गोक्षुरादि घृत कौन सी फार्मेसी का अवेलेबल हो सकता है? देखिए, गोक्षुरादि घृत इज क्लासिकल. Mostly at here, everything which I have mentioned, it is classical. And generally, I never prefer the branded medicines. It doesn't mean that I am just criticizing the branded medicines, but I do not have much more experience about the branded medicines because I am not writing many branded medicines, so I have not experienced. So I cannot say anything. But Goksuradigrit is the classical form of the Greek. So it can be available. It is the Sharangar Samhita.
इसमें आ रही है, उस वाले में आ रही है, शायद ये डिस्चार्ज हो गया है, ये डिस्चार्ज है.
So you can take the question from the chat box.
How to taste microalbuminuria? In microalbuminuria, only the possibilities is just 24 hours urine albumin. Then you can judge that is microalbuminuria or how much amount the microalbuminuria is there. Because actually albuminuria or proteinuria, they are four kind. One is microalbuminuria, then macroalbuminuria. These both are the selective proteinuria. And then third one is the non-selective proteinuria. In non-selective proteinuria also the two different kind. The one is the non-nephrotic range of the proteinuria and another is the nephrotic range of proteinuria. So in microalbuminuria or any other albuminuria or proteinuria, only the ideal measurement or measures are 24 hours proteinuria level. हाँ, नीरू बस्ती कितने टाइम तक दे सकते हैं या कब तक डेली देते रहना है? हाँ, हम लोग तो वी आर यूजिंग द डेली because we are using only 320 milliliter amount of the Niru Basti. And generally, if patient having any signs and symptoms related to the Vata aggravation, then we have to discontinue it for a few days or for that particular time period. Or in optional, you can give also Guksuradi Grit Matra Basti for 1 or 2 times. विरेचन का विचार करना हो तो किस मेडिसिन को सिलेक्ट करें, कितने डेज दे सकते हैं? नहीं, विरेचन को नित्य विरेचन के हिसाब से यहाँ नहीं लेना है। विरेचन को मतलब कि अगर पेशेंट in the first or second stage and if patient do not have the signs and symptoms related to the fluid accumulation or electrolytes and water disturbances, only on those patients you can go for the snehapana and then virechana as the classical virechana karma. और उसके लिए जो भी मेडिसिन आप सिलेक्ट करें हैं, लेकिन कोई रसौषधि वाली या जयपाल वाली यूज करने की जरूरत नहीं है। देखो क्लासिक्स में एक है कि अगर सम्यक स्नेहपान हुआ है और दोषों का पूरा अगर ठीक से विलयन वगैरह हो रहा है तो अपने आप कोष्ठ में आने ही वाले हैं, है ना। तो उसके लिए सिर्फ बाद में थोड़ी सी मेडिसिन लिख दी जाए तो भी उससे अच्छा विरेचन हो जाता है, क्योंकि हम तो यहाँ सिर्फ दीनदयाल चूर्ण और एरन स्नेह देते हैं तो भी 20-20, 25-25, 40-40 विरेचन के वेग हो जाते हैं केवल उसी से, है ना। तो स्नेहपान प्रॉपर होना चाहिए और अभ्यंग सेदन ठीक से होना चाहिए। What can be given to a pregnant lady who is in her second trimester and diagnosed as renal calculi during the ultrasound? Okay, renal calculi, it is also Ashmari, and Mutrashmari is mentioned in the Pakvashaigat Vat. The one of the Lakshana of the Pakvashaigat Vat is Ashmari. So, in this case, you can go for the Niruha Basti. Because in the second trimester, I think, see, still I am confusing, huh? Because I have not so much practice about the gynecology. So whether the Nirubasti is indicated in the, I don't know. So please use cautionly. Actually, this is some gynecologist also have to give the answer. I am sorry, I am unable exactly to answer this question.
सभी क्वेश्चंस हो रहे हैं, अगर किसी को और क्वेश्चन है तो
सर आवाज कट रही है सर।
ओके, थैंक यू सर। और जुड़े रहे, ये आपका जो प्रैक्टिकल काम है इस टॉपिक के ऊपर सही नतीजा है, इसके सब जुड़े रहे और सबके सब और आपके फ्यूचर समाज से लोगों पे भी अगर संरक्षित समझेंगे तो कुछ डिमांड आ रही है पीपीटी की, अगर संरक्षित समझेंगे तो वो उस ग्रुप पे सर ऐड कर देंगे तो वो पीपीटी को पे शेयर कर देंगे बस।
जरूर जरूर।
तो हमारे डॉक्टर को करूंगा कि वो आपसे करेंगे सर। कोई और कोई भी कहना चाहता है तो उससे पहले कह सकता है, तो आई विल is assistant professor in Kayachikiotsa, Government Ayurveda College, Delhi.
हाँ, धन्यवाद डॉक्टर नितिन। मेरी आवाज आ रही है?
हाँ जी, आ रही है।
हाँ, ठीक है, थैंक यू अगेन। आज जैसा हम जानते हैं कि हमारा देश आजादी के 100 वर्ष पूरे कर रहा है 2047 में, और देश इसको आजादी का अमृत काल के रूप में मना रहा है। हमारा आयुर्वेद भी इसी को आयुर्वेदा @2047 के अंतर्गत हमारी आयुर्वेद की जितनी भी 14 विषयों की सभी संभाषाएं विश्व आयुर्वेद परिषद द्वारा संपादित की जा रही हैं अपने लक्ष्य को प्राप्ति हेतु। उसी क्रम में जब हम ऐसी असाध्य बीमारियों को, जहाँ पे हम पहले ये सोचते थे कि आयुर्वेद शायद हम इस स्टेज में हम चिकित्सा के लिए थोड़ा सा कहीं हमारे अंदर संकोच होता था, और ऐसी व्याधियों की चिकित्सा में भी हम आज देखते हैं कि आयुर्वेद काफी अच्छा अपना रिजल्ट दे रहा है। उसी क्रम में ऐसी एक व्याधि क्रॉनिक पेरिनकाइमल डिजीज या CKD पे आज की हमारी आयुर्वेदा की जो अपनी काय चिकित्सा विभाग की हमारी जो संभाषा है वो आयोजित की गई, और उस संभाषा में हम आज के अपने गेस्ट स्पीकर प्रोफेसर मनीष कुमार वी पटेल सर को, हेड ऑफ डिपार्टमेंट काय चिकित्सा डिपार्टमेंट, JS आयुर्वेदा कॉलेज एंड नाडियाड गुजरात को, सर को मैं कोटिशः धन्यवाद और सर का अभिनंदन करता हूं अपनी परिषद की तरफ से, जो सर ने अपने बहुमूल्य समय से अपना समय निकाल करके हम सभी आयुर्वेद के लोगों के द्वारा अपने जो एक विचार रखे, अपने ओजस्वी विचारों से हम सभी जो चिकित्सा में रुचि रखते हैं उनको एक नई दिशा, एक नई सोच प्रदान की। सर, हम आपको विश्व आयुर्वेद परिषद की तरफ से बहुत बहुत धन्यवाद ज्ञापित करते हैं कि जो आपने अपना बहुमूल्य समय हम सभी को दिया। मैं धन्यवाद देता हूं अपनी विश्व आयुर्वेद परिषद काय चिकित्सा संभाषा टीम को, प्रोफेसर JS त्रिपाठी सर को जो कि हमारे कन्वेनर हैं काय चिकित्सा परिषद के, डॉक्टर मनदीप गोयल जी को, डॉक्टर नितिन शर्मा जी को, डॉक्टर मंजुला जी मैडम को, जिनके सतत प्रयास से हम एक अपने नियत समय पे ऐसे मनीषियों को अपने बीच में लेके आते हैं, ऐसे ज्वलंत विषयों को हम अपने सामने लेकर के आते हैं जिनसे हम अपने जितने भी आयुर्वेद में चिकित्सा के क्षेत्र में कार्य करने वाले लोगों को नई दिशा मिलती है। हम अपने छात्रों के बीच में भी इन सब चीजों को लेकर के जाते हैं, और आयुर्वेद का एक हम सतत एक जो विकास है उसमें हम अपना सफल रहने का प्रयास करते हैं। मैं धन्यवाद देता हूं अपने सभी जोन वाइज कोऑर्डिनेटर्स को, जो कि अपने सभी जोन्स में अपने इस परिषदों की क्रियाकलापों का प्रचार प्रसार करते हैं। मैं धन्यवाद देता हूं अपने विश्व आयुर्वेद परिषद एग्जीक्यूटिव कमेटी को, जिनके मार्गदर्शन में सभी परिषदें सतत सक्रिय रहती हैं और अपने अपने विषयों में जो भी हमारे मनीषी गण हैं उनको अपने साथ में जोड़ करके हम सभी के बीच में लाते हैं और उनके विचारों से हम सभी को अवगत कराते हैं। मैं पुनः अपने सभी जो आज की हमारी संभाषा से जुड़े देश के विभिन्न क्षेत्रों से जो आयुर्वेद के अपने विद्वान, तो हम उन सभी को भी अपना जो बहुमूल्य समय निकाल करके हमारी आज की परिषद की संभाषा को उन्होंने उसमें ज्वाइन किया, उन सभी को मैं बहुत बहुत धन्यवाद देता हूं। डॉक्टर नितिन, इसके पश्चात अगर डॉक्टर नितिन हो तो शांति पाठ के लिए सभी को।
थैंक यू सर। मनीष सर, बहुत ही अच्छे रिव्यूज हमारे ग्रुप पे और इस चीज पे आ रहे हैं। आपका लेक्चर तो बहुत ही ज्यादा पसंद किया गया और बहुत ही लोग आपके इस लेक्चर से खुश हैं और बहुत ही ज्यादा एक मोटिवेशन मिला है इस फील्ड में काम करने के लिए। थैंक यू सर।
मैं सभी से
डॉक्टर शांतुल, आप शांति पाठ कर दीजिए।
मैं सभी से आग्रह करूंगा कि शांति पाठ तो अपना सीधे होके बैठ जाएंगे और मैं बोलूंगा, आप लोग मन में दोहराएंगे उसको। सर्वे भवन्तु सुखिनः, सर्वे सन्तु निरामयः, सर्वे भद्राणि पश्यन्तु, मा कश्चित् दुःखभाग् भवेत्। ओम शांति शांति शांति। सभी को बहुत बहुत नमस्कार, बहुत बहुत धन्यवाद। डॉक्टर नितिन।
ठीक है सर, थैंक यू डॉक्टर शांतुल, एंड थैंक यू एवरीबॉडी फॉर ज्वाइनिंग today's webinar. And like this we conduct every month this Kayachikiotsa Sambhasha. for the teachers and the faculty members of the Kayachikiotsa and all others who want to join and engage their clinical practice. Thank you, sir. Thank you very much.